Good evening all. This is a comparative study of accuracy of thoraco-lumbar-sacral pedicle screw insertion based on routine use of intraoperative imaging in 3D navigation at comparison between the spine consultant and the fellow. Since the introduction of pedicle screws over the decades, the pedicle screw constructs have gained popularity, and since the advent, the spinal fusion surgeries after using of pedicle screws has shown great success due to increased biomechanical strength, rigid internal fixation, and ability to hold better corrections and fusions. However, there are lingering concerns over the risks of screw malalignment, malplacement, and associated complications, where risks as high as 50% in thoracic screws have been noted. The main concern will be the medial breach, which penetrating into the canal, causing a neurological deficit into the spinal cord. Superior and inferior malpositions affect the exiting nerve roots. In addition, there's anterolateral perforations causing potential vascular and visceral damage to aortas and the major vessels, esophagus and the trachea and the upper thoracic region. Along with that, there's significant risk to the operating surgeon when compared to using the radiation, using the C-arm, where the risks are due to the radiation exposure. Current practice, there is use of 2D C-arm with no navigation and 2D C-arm with intra-operative navigation. But there is a lack of information of the axial cut, that is the third dimension, and also the relative positioning of the patient's anatomy and the surgical instruments which come in the middle. There are few studies which have shown accuracy as low as 72% to as high as 92% using C-arm without any navigation. So this study was to evaluate the accuracy, the rate of pedicle screw malpositioning, and compare the efficacy of and accuracy of placement of pedicle screws between an experienced spine consultant and the fellows under his study. The inclusion criteria were patients who underwent pedicle screw fixation at the level of thoracic and lumbosacral spine using O-arm. The study was conducted in Koklaban Hospital, and duration of study was between 2017 and 22. It was a retrospective type of study, and Medtronic O-arm 2 with Stealth Station 8 was used. The breach or the malposition was classified based on Gutzbein's classification with grade 1, 2, 3 as less than 2 mm, 2 to 4 mm, more than 4 mm breaches. This is briefly how the navigation system is used, where the trajectory can be seen right away from the entry point, even without entering the skin. This is the projection which seen on the O-arm navigation screen, where the projection can be seen into the pedicle. And the trajectory and the screw length can be checked as you enter the pedicle. Also, the thickness of the pedicle can be measured, and real-time tracking of the screws can also be done. Once you place all the screws, the 3D orientation of the screws can also be done to measure the rods. This is classical Lenke maneuver, where we use in Angst-Pond case, where you can see the Lenke is turned outwards while entering and enter the pedicle. Once you enter the pedicle, then turn the Lenke 180 degrees to turn inside and enter the pedicle to the into the vertebral body. So the accuracy here the knack which we usually use to feel the pedicle is not useful because the bone is of sclerotic in case of Angst-Pond. So here the feel is obviated. Few cases. There's a case one where 82-year-old male comes with difficulty in walking since past 6 months and previously was operated for the same complaints 2 years back. He was operated with thoraco-lumbar-sacral fusion using navigation based and along with decompression. A second case where an 80-year-old male comes operated for LCS with decompression 4 years back and presents with worsening symptoms and was wheelchair bound for the last 3 years. Same thoraco-lumbar-sacral fusion with S2 iliac screws were put using navigation. Results, patient demographies, total of 2,676 screws was placed, where various pathologies where pedicle screws were needed to be inserted as follows. And according to distribution, 1,082 thoracic screws and 1,595 lumbosacral screws were inserted. Where a total of 1,573 screws were inserted by the chief consultant, and a total of 1,104 screws were divided among 2 fellows under his study. Total of 5 breaches of grade 1 were noted, where 3 thoracic and 2 lumbosacral breaches were there. All of them were grade 1, basically indicating in-out-in technique in deformed pedicles were noted. Similarly, total of 9 breaches were noted by the fellow, where 4 and 5 expected in thoracic and lumbosacral area. The mean age of the patients who underwent surgery was 51 years. A CT scan obtained intraoperatively. Pedicle evaluations were noted in 14 of all the 2676 screws inserted. 5 of the, as I said, 5 of 1500 screws and 9 of 1100 screws were seen. There were no grade 2, grade 3 breaches in either of the hands. None of the screws needed revision, and none of the patient needed revision spine surgery. There were no major catastrophic complications due to screw malposition. So 3D navigation precisely increases the accuracy in various surgeries, including MS, deformity, tumors, cervical spine, as well as offers special projections where the field obviated, as in case of very osteoporotic bone or angstbone cases. A paper in Eurospine by Silverman et al. Showed that the accuracy as high as 100% was noted, with decreased revision rates and decreased operative time were noted using 3D navigation. The conclusion of the paper says the use of O-arm based navigation can improve the accuracy, safety, as well as reliability of pedicle screw instrumentation. The accuracy of pedicle screws placement is same in the hands of an experienced spine surgeon as well as a newbie spine surgeon. This study is a small sample, single center based study, hence various multi-center study need to be done to confirm the results. Thank you.